The camera over here. Say hi. So Matt is getting us kicked off for week interview
19? I think you said 18 last week.
I think it's 19. Yeah, how are we all doing?
Alive and well.
I feel like the energy is low.
Fantastic.
Yeah, we need an energy boost here. Somebody yell really loud.
Leave that up to Maddox here in about 5 minutes.
Woo! No, we're back. Moderator for today is Daniel.
Daniel
also turned 30. When was the actual date?
Last Friday.
20... Okay.
Hip replaced on Monday.
That's right. Yes, going downhill fast. I'm going to call on our extern real quick. Do you know where my bourbon is? Did you steal it?
I thought you set it on the table with Brother Mike.
Probably put it in there to get ice.
Somebody can't find it. And if you can't tell, this is my assistant for today taking notes. Beep boop, beep bop. So we're going to get rolling. So yeah, Daniel's moderator. Sloan's got a case. We're actually going to let Sloan.
I don't think I should open.
Why not?
Okay, I'll open. Mine's just atypical and it's me, so it's going to be long-winded.
Okay. All right. All right, you're up.
Okay, when I started kind of writing out this case, per the usual, it was starting to get really long. And this one's really super important to me. Not like all patients are important to me, but this case in particular is very important. And so I don't want to rush through it. So what I'm going to do with this is it's going to be kind of a series for me. So we're going to go over this over the next couple podcasts and kind of follow this gymnast progress and
We didn't say that you're allowed to do series.
journey, if you will. Well, I made my own rules this week and for the next couple. I think it'll be worth it rather than me like speeding through it and taking 37 minutes.
Producer first.
Okay, well, here we are. You'll allow it. Moderator will allow it this week. So I kind of want to just paint the picture, get us started talking about this topic. I've seen this gymnast 4 times. I've seen this gymnast over the last couple years, but for this particular ailment, I've seen her 4 visits now, and she's making incredible progress. But like I said, I'm going to kind of drip that over the next couple podcasts. So let's just kind of paint the picture to start with. She's a 15-year-old level 10. She's a future collegiate gymnast. She's got a couple different colleges that she is speaking to. And so she just has like a really bright future with gymnastics. And I say that because at 15, she's already done gymnastics for at least a solid 10 years. She's doing it 30 hours a week. But at 15, she still has 3 more years of high school or junior Olympic gymnastics. And then she has 4, maybe 5 years of college gymnastics. So she still has 8 years left at least. And so, what would that be? 3, that's 7. 7 years of high level gymnastics left. And so that comes into play, and that comes into play with our conversation I had with her later. She presented to me, I want to say about mid-July, with acute mid-back pain. This was after a couple college gymnastics camps that she went to. So these are large workload events. These are lots of gymnastics for a couple days in a row. So there's very, very little time for recovery. Towards the end of her second camp, she was doing a drill that required this large amount of extension into a snap into a large degree of flexion. So she goes into...
I feel like they should call that move a pickle.
It kind of looks like a snapping pickle, if you will, but it's called a hect. A hect. It's in particular to Kotcheff in gymnastics, but a hect is this like quick change in direction. So you go into this large amount of full body extension, and you use that force to snap you into a great degree of flexion. And she felt this immediate tightness within her mid back. Later that day, she was able to continue, but she just reported a lot of tension, a lot of achiness. And over the next 2 weeks, after returning to practice, it slowly worsened. By the time I saw her, she really couldn't flex forward. So this is a really flexible, high-level gymnast that couldn't even come close to touching her toes. Couldn't flex forward. Extension actually felt pretty good. And she just reported a lot of tension and achiness, and then with flexion, a lot of sharp pain that wrapped around both sides of her rib cage. We want to say kind of around maybe T8 to T10 area.
Did you say T8 to T10? What was that? What area are we talking? T6?
T8 to T10.
Okay. Okay. I was just checking.
Anyway, to move on here. Good, we are recording. Okay, so moving on. I'm going to leave you kind of with that small bit of history, and then I just want to speak to the history that I've had with my experience within treating gymnasts in particular, and what I've done with Gymnast Fix. Is my goal with Gymnast Fix primarily has been targeting the epidemic of low back pain within gymnastics, and that's been majority of the ailments that a gymnast walks into within my clinic is particularly within the low back. And it usually either turns into a diagnosis of a spondylolysis or a spondylolisthesis, or it's trending that direction and we have to put a stop to it and we change your patterning so that we prevent that from happening. But I'll say this, over the last couple of years, that pattern of low back pain is really changing and is kind of morphing higher into this mid back pain. So I'm seeing less and less low back pain walk into the clinic and more of this mid back pain. And in the beginning, this kind of stumped me. I'm like, mid back pain, are you just straining? Is this like straining of muscles? Is this just tension through the TL junction? But I'll say over the last handful of cases that we've had in this area, I've learned a whole lot, and it's alarmed me and kind of pushed me to investigate this further. And this is why I want to talk about this so much today. And I don't know why exactly it's morphing. Is gymnastics changing? Is the skill demand changing? Is our personal environment changing? But something, whether it's the gymnast or the sport, is morphing these typical injuries that are low back into this mid back range. So I just want to speak really fast. I'm not going to go into detail about our exam. It was fairly cut and dry. I just wanted to ensure that there was zero neuro deficits. But because of the history of the past couple years of these mid-back cases coming in, I knew immediately once she talked to me about the mechanism of injury that I needed an x-ray. Oh gosh, I wanted to pull the exact wording from the x-ray and I completely spaced.
Mm-hmm.
Okay. So the x-ray showed history of multi-level Schmorl's nodes. Also showed some,
When you say multi-level, where?
Mid thoracic spine to lower T-spine.
So basically where she's hurt.
Yeah. And then there was some edema within the front of the anterior, that was MRI. Okay. There was early wedging of the lower T-spine. So the anterior part of the body of the thoracic spine, thoracic vertebrae were starting to actually decrease. So we saw early wedging. We saw a little bit of disc space narrowing. So I knew at this point we needed to move forward with MRI. I wanted to see at what extent, and what I really was looking for ordering this image, the first thing I wanted to rule out is active compression fracture. So what I've seen in the past is compression fractures of the lower thoracic vertebrae that have led to early disc degeneration of the lower thoracic area. In fact, I've had gymnasts that the thoracic disc is completely gone by the time they're 17. So in this 15-year-old, I wanted to make sure that she was not going down that path. So we ordered the MRI, and the MRI, the radiologist actually reads, this is not a normal MRI finding of a 15-year-old, because if I were to have like the 45-year-old or the 50-year-old come in and we would have had this MRI report for them, I would have been like, you know what, this happens. Like this is like getting gray hair. We start to see degenerative change, no worries. We can work around this, but the conversation changes when she's 15. So MRI shows early degenerative change within the disc. I think it actually said disc disease at that point, multi-level vertebral body wedging, multi-level Schmorl's nodes, and then inflammation within the L1 vertebral body on the anterior side. I wanted to also speak on her personal history. Over the last 6 months, she's grown several inches. Genetically, her family is just very tall. And I think gymnastics has kind of kept her short, and then her genetics is catching up with her. And so she has just sprouted. I mean, she's grown a handful of inches over the last year, and she's still trying to do these hard skills within gymnastics. So it puts a lot of stress on her. And you can imagine when we're growing, those end plates are nice and vulnerable. They're open. And while I'm trying to do hard level skills, they kind of suffer the impact of that. Something else, when we watch her move, kind of a functional assessment within the clinic, when we watch her assume any sort of taxing position, like a plank, something that we call a TRX fallout. So we stand up with TRX, what would you call those? Straps, TRX straps. I don't know, rings, and then just have her kind of fall out into a plank, which honestly should be a fairly simple position for a high level gymnast. She immediately falls into this typical posture of hers, which is this hyperkyphotic position and this extreme like hyperlordotic position. And that's her stabilizing position. So for hours upon hours at the gym, when she goes to stabilize, whether she's tumbling, vaulting, swinging, whatever, she hits this position. So again, let me kind of describe it for you. From about mid thoracic to lower thoracic, it becomes hyperkyphotic, so very rounded. She doesn't qualify for every needed point for Sherman's, but it's almost like on the way to Sherman's. So she gets this hyperkyphotic position in the mid to lower thoracics, and then this hyperlordotic in the lumbar spine, and then she pulls the hips into extension underneath her. And I'll say this, in gymnastics, this is a really coveted position. It's like aesthetically very beautiful. It swings very well on bars. It's pretty. It creates this straight line and this hollow upper body. But you can imagine that position is not the most advantageous for loading of the spine.
Mhm.
Would you guys agree with me?
Yeah.
Okay. So if we have a skeletally mature individual and they're tumbling and absorbing axial compression through a hyperkyphotic thoracic spine and a hyperlordotic lumbar spine, they're going to be okay. They may not be able to produce as much power as someone with like a more preferred posture, I guess you could say. But we take the 15-year-old that is under this incredible growth spurt right now, and she has these really vulnerable vertebrae, and we've created a load distribution that's potentially harmful to those end plates or those growth plates. And that's what we see within her imaging, is that she's kind of been destructive through those end plates because of how she's loading her spine in that position. So I always kind of tell this to my girls, is like the best athlete adapts, and her body is adapting. The bones are actually adapting. Her disc space are adapting, just not in the way that we want them to. And so we have to have the conversation with her. Okay, I can get you out of pain. And we got her out of pain. That very first visit, we did some thoracic extensions, and she's like, holy cow, that feels way better. She could touch her toes before she left. I mean, from barely bending forward to I have no pain leaving, like that's awesome. But that's not our goal. That's not our job with her. That almost actually probably puts her in a more dangerous position, being completely out of pain. So we have a few goals with her. Like I said, I'm going to go over these, our progress with her over the next few podcasts. But what we have to do with her is we have to change her current stabilizing strategy. So her current stabilizing strategy is this hyperflexion through the mid to lower T-spine, extension through the lumbar spine. We've got to change that. We're going to do that through DNS positioning in the beginning, which she's already achieving really well. We just have to be able to do that while she starts disassociating her upper and lower extremities in gymnastics, which we're getting to. We've had conversations with her regarding her goals and timeline, and it's just an absolute must for her future health of her spine and disc that she changes that stabilizing strategy. Okay, with all of that said, and I wanted to point out, I wanted to go into a lot of detail over this because I really believe this is kind of that next, air quotes here, spondylo in the sport of gymnastics. You know, I've seen this transformation from low back pain being the primary complaint to now this mid back pain. And I just think it needs a lot of focus, and I think it needs a lot of understanding. So next time we'll talk about her first couple visits with me.
So without going into another case, how would you explain another gymnast with this similar pain who's not going through this same growth spurt?
Okay, well, like I had another gymnast that this was career ending because she had already like finalized that growth period for herself. She was 18. She had numerous college offers, but she no longer had disc. I believe it was like T11, T12. And at that point, she can't absorb axial compression without damaging bone. So she had to have the hard conversation and the hard decision, is it worth another 4 years of gymnastics to potentially create more pathology within my spine?
Yeah. The other thing I'm thinking is, again, I can see your little one over here to my right. So it's not like you necessarily have time, but how much of this is just the athlete to like the training, everything going on to like maybe put more of an emphasis on the upper mid back. I don't say upper back, more mid back than low back. Are they doing anything to change how they're training?
Oh, we've completely overhauled her training. I've met with her coaches, parents, everyone's on the same page. We've stalled and stunted everything for right now. Unfortunately, she's got college coaches coming to visit her. So it's like she has to do enough to keep them baited, I guess.
Mm-hmm.
But at the same time, we have to slow her down enough that she actually makes motor pattern changes.
Mm-hmm.
So it's tough. It's tough. Good thing is we're not in season right now. And so she can do that, but there has to be complete transparency between the coaches. I've had this conversation too with the parents. She could come to me once a week forever, but that once a week in my office is going to do nothing compared to the 20 to 30 hours she's actually doing gymnastics. So her training's completely overhauled to focus on changing her stabilizing pattern.
Very cool.
I hope that was
What are you gonna name
fluid enough. I mean, you have coined it.
Is it the same thing though? I don't think it is. It's not. No, it's not at all. It's not.
I think it's the same thing at an earlier age.
No. TL junction flexion syndrome would be scalping the T-spine, not hyperkyphosis. So it'd be different. And totally different reason too. We're saying that's coming from training versus development.
Yeah.
So I'd say it's different.
Yeah, I guess we got to come up with a name. Someone that I highly respect. It's a fun noise, Maddox.
I would call it the pickle.
The pickle. Someone I highly respect within the gymnastics world, and I hope that if we have listeners listening to me in particular because of the gymnastics viewpoint, I hope that you're following him. Is Dave
Tilley.
Dave Tilley. Excuse me. Wow. A DPT out of Boston area, I believe, but Shift Movement Sciences, I believe is the name of his kind of platform. But he's mentioned before having that lower, like he mentioned how odd it was, this thoracolumbar area pain. And I think he treated it like discogenic. And I was like, oh, we got to rule out compression fracture, because those kind of minimal or minor compression fractures is basically what's happening at the end plate, right? It's just over time, a lot of multiple happening. It's not this one big compression fracture. It's just a lot of that.
Yeah. Well, I think I could continue asking questions, but since you're going to go on many cases with this, I won't bog you down with it.
Yeah.
And
I really hope that was said in a way that you all could understand. And if it wasn't, please ask questions and I'll try to detail it out a little bit better.
yeah. All right.
Oh, me? You?
I think
Rock, paper, scissors.
break up the female voices, maybe.
Okay. Monica's still waking up from this morning.
I tried to take another nap.
It's
and it didn't work.
almost 2:40. We might get there by 5. Nice to
It's a
sleep.
7 a.m. patient. I don't know what it does for me.
Now I got to look at my patient. So I actually changed what I was going to do just in the past hour based on the last patient that I saw. So I was going to do kind of a interesting case that I actually did in residency in the follow-up to that, but yeah, I'll talk about that at a different time. So I had a patient come in today that I've seen for, I want to say it's the person that cuts my hair. They do a very good job. I'm growing it out, so this is not her fault right now. She actually said it looked really good, so I'll take
The volume is impressive.
Yeah, you're welcome. You get to live with this every day.
I love it.
This is a low volume day too.
It's like I don't even need a cup of coffee in the morning. I should roll over and see that volume.
Tell me about it. So I've seen her for years for various things. A lot of foot stuff, a lot of kinesthetic awareness, things like that. I don't know. She wouldn't mind me saying that. She has low kinesthetic awareness. She's not a great like conceptualizer of her own movement. So she came in, I want to say 3 months ago, and was having pretty significant vertigo symptoms, mainly like BPPV, right? She lays down, she has some vertigo, it kind of would dissipate. She sits back up, has vertigo. She'd had it one time prior in her life for like 2 days, self-dissipated. She never did anything about it. So this time she's like, this is getting like pretty bad where like I'm staying in bed, right? By the time she seen me, I think it'd been like a week and a half. So she had not seen anybody before me. And I'd seen her before and I knew she had some eye tracking issues and things like that. So my first thought was, and we had worked on, remember I said she had kinesthetic awareness stuff, some foot stuff. We'd done some like midline balance work, all these things. And we always were using her eyes as a catalyst to change. And Daniel and I were having a whole conversation on like visual cortex system and like what we're actually doing with rehab, if it's an input or an outcome, but that's a totally different conversation. Anyways,
Real quick on that, it's like the conversations that like me, you, and Sloan used to have before Monica came along, where I'd always think, if we could record this,
right,
this is where everybody probably wants to
actually like hear this stuff. Yeah.
The debate.
So she comes in, well, I'll give you the whole backstory. So she came in then and was having vertigo. We did some maneuvers because in the state of Alabama, you're not supposed to do those maneuvers, which is a bunch of bullshit. So I don't care because it's a stupid maneuver. But like, yeah, in the state of Alabama, as a chiropractor, you're not supposed to do Epley's maneuvers or anything like that. It's Hall Pike, which is just asinine. It's supposed to be DO. PTs are allowed to do it for some reason. I don't know. Just whatever.
People look it up on YouTube and try it themselves.
Right. So, and it's literally turning your head one direction or the other, assisted free fall, and then let your head hang off the table, bed, whatever. Like, I don't know, whatever. So we do that. And what you're trying to do with that type of maneuver is what? Find directional preference of like, this way makes it worse. That's actually where you work, right? Usually. I mean, there's not like hard fast rules, but so that's what we did. Made it worse, worked on it. You're trying to like recondition. There's a lot of hypothesis. I don't think the otolith coming back into place within the semicircular canal is what's actually happening. I think you're just reconditioning movement. But anyways, we do that. It knocks it in half of what it was, right? So she's like, and this wasn't on the spot. This was like days later. She's like, that really helped just working on that same stuff or that stuff. So I see her maybe, I think a week and a half later, she comes in, she had on her own accord, went to a PT that she works with, different stuff, maybe done some different stuff. He was saying there was a cervicogenic component, which there was not. Did some soft tissue work, nothing changed. So obviously that was not the thing, right? I didn't think it was. He did work on it. He didn't change. And even said at the end of the visit, I don't think that's what it is. Okay. So we take that out, but she's starting to get more and more miserable. She's like, it's not changing. I think it's getting worse. I was like, there's more eye stuff going on than than I feel comfortable with treating on my own. And her eye stuff, if we're looking at it, if I go through her, if I even have it in here, I have what we did. But so in particular, like a vestibular ocular reflex, which is basically your ability to either lock in on a target, right, and move your head around, or a BORC, which would be vestibular ocular reflex cancellation, right? My ability to track both moving together, right? Where I'm moving everything with the target. When we go in the upper left, right, lower diagonal pattern, everything falls apart and symptoms worsen, right? She can't do it. It's discombobulated. She also has a left convergence issue. And that's what we said when we're like, dude, her eye is jacked. I was just like Michael Jackson, like, we got to work on this. So we started doing some just convergence push-ups on that left eye, but I took her down into half kneeling and had her start doing what I call narrow or narrow base balance progressions. So we start in normal base, right? And we typically take it down and we'll pick a target and then we have them work through cervical rotation on that convergence side. So if she can't converge on the left, she'd be going through left rotation. And then we narrow the base, right, to try to destabilize her system and see like, well, where do we go? We've worked on this in the past with her feet, right? We're using the same concepts. So I knew something was there. I just didn't ever expect it to present it like this. So we're working on some of that stuff. She would note that it always got better around that, but I think what she said today, she would get like maybe 15, 30 minutes of relief and then it would kind of come back. So I haven't seen, and I was like, hey, you need to go to, well, I actually sent her to an optometrist in between the first and second visit. She went to her optometrist who said, nothing is going on with your eyes whatsoever. And I go, you need to go to a different optometrist. So there's a local behavioral optometrist that I really trust, or optometrist that does also behavioral optometry. And I go, you got to go see her. And she goes, okay. So it took a little while to get in her. She goes and sees her. She goes, yeah, something's going on. So she comes in today after I haven't seen her for a while. And she's been to the behavioral optometrist is doing work. So she comes in with glasses. And again, we talked about this and she called them this. She looks like a minion. These are blue framed round glasses with a screw in the middle where you can unscrew the lens tightness. And then you can move the lenses so you can dictate where your eye is going to have to focus. And that's what they're a training aid. But these things, and then they go around with elastic band. So she looks like Horace Grant and a minion had a baby.
Just real quick on that.
Yeah.
Have you done much research with that? Because I know I have not,
With
those particular glasses and like how much the effective actually is.
yeah, but the thing is with those, so you're turning the lens. So what you're gonna see if they made if she got a pair of eyeglasses, just the bare bones, like, hey, what would you need if you have a convergence issue, right? This is just in general. And this doesn't mean this is right. They would move the focal point in. So when your eye has to focus, it has to move into convergence and work that pattern. Same reason you would patch a good eye in a kid that can't converge. So now they have to force convergence as they look at things up close. That's what you're always patching the good eye in that case. So she gets these glasses, she's working with them. She goes, if I wake up in the morning, my symptoms are absolutely worse. I put the glasses on, they're about cut in half, but I'm still bad. And she's to the point where she, again, is a hairstylist. And when she says that when she's cutting hair, she's having to concentrate so hard on each piece of hair that she's cutting that she is just like mentally and physically taxed at the end of the day. And then she just goes home and goes and gets in bed, both because of like the drunk feeling and she just like wore out from concentrating. This is somebody that's taught in cosmetology school, all these things like high level, hairstylists. So she, in the meantime, she has also so she saw the behavioral optometrist has done 2 follow-ups with her. It has a bunch of different eye charts that she's doing drills and things like that. She had seen an ophthalmologist. The ophthalmology visit was very interesting. And this is from her. This isn't me speaking to the physician, which said that the ophthalmologist was doing her exam and was being followed by a resident. The ophthalmologist initially said, nothing's going on with your eyes. And the resident spoke up and said, I think something's going on with tracking. And I don't know what they were thinking, right? I would assume it's what I'm seeing, convergence issue, VOR, tracking in this upper left quadrant. So then she said that they exit the treatment room, go out in the hallway, she can hear them arguing. They come back in, they redo the exam, go back out, have an argument, redo the exam, go back out, have an argument, come in a 4th time, redo the exam, have an argument in front of her. And the ophthalmologist finally says or the resident finally wins over the ophthalmologist. And the ophthalmologist is like, yeah, I think something's going on. You need to go see a neuro-ophthalmologist. Goes to a neuro-ophthalmologist that she's referred to, has an MRI in between then and between that appointment and there, because that's what they're requiring to get in. She hasn't had the follow-up with him, but he did have an initial visit, hasn't had the follow-up from the MRI results, but he just initially was like, something's going on. We need an MRI. I won't make any, decision or prognosis before we see the imaging. So that's what she shows up with today. Minion glasses, still feeling mildly drunk all day, being extremely taxed by cutting hair, waiting on MRI results, which are going to come back next week. So she says to me, I feel like I need some sort of balanced vestibular work because we're just focusing on my eyes. And my initial retort to her was, you're coming in here working on one thing, and that's almost like putting an orthotic in a shoe to get your foot to be functional. It's still not functional. If we go ahead and start working on all the other stuff, that may not be the best option, right? I don't know that because there's a level where I have to kind of tap out and say this is out of my realm, right? But I was like, well, let's just do an exam and see what happens. So we, with her Minion glasses on, their behavioral optometry training glasses, we go into a half kneeling stance and we're working on VORC in that left upper, right lower, still terrible. We're also just doing our narrow base balance, like convergence. We're also doing saccades, right? We're going right to left on dots for like 30 seconds at a time. And she like kind of comes apart at 15 seconds each time. So we only do, I think, 3-4 minutes work total. And then we talk a lot. So I get a text from her maybe a half hour later saying that she's in the grocery store and she feels like her legs, like her quads, and she says her quads and ass are shaking so much, it feels like she just did a bunch of squats. And I'm like, do you feel like something's wrong or you're just fatigued? She goes, just fatigue. Now, can you get neuromotor fatigue from stuff like that? Sure. That's pretty excessive, right? That's very excessive, especially for the amount of work we did. I mean, they have entire like central nervous system fatigue gains that are upwards of 90 minutes long, right? There's a lot of eye tracking stuff. So 3-4 minutes.
It's not like she's not an active person either.
Right. I mean, much less active since this. And that's one thing I asked her, like, trying to rule other stuff out, right? Changes in heart rate aren't affecting. It's like trying to make sure there's no vascular insult. We haven't had, but this is, I know it's hard to kind of like gather all this data into a good case study because it's like, what exactly we're seeing. Like, again, I told you convergence issue, VORC left to right is the worst that we're seeing. Or even that goes into just pure gaze stabilization too. But the big thing that I worry about now is that she actually has a lesion. Right. And that's what I kind of told her today. I go, I don't feel comfortable going any further. These drills are benign, right? If they make you worse, stop. I don't think we're going to fix anything while you're in training glasses, all this stuff. And she doesn't know this, but the stuff that she's being sent home from behavioral optometry is actually diagnostic. It's not that much therapeutic stuff.
Yeah.
She's trying to figure it out, just like we would send somebody home with exercises. It's all red, green color charts with pathways, right? With +2 and -2 bifocals that are trying to kind of elicit a response. So my last piece of advice for her, just kind of thinking off the cuff, was to try to help her with work, because she took 3.5 weeks off work. So she's in this point where she's like, I have to kind of work now. I can't just keep taking that time off. So I said, you need to go to Walmart and buy a +2 and a +1 pair of reading glasses, punch the right lens out, and just see if you can wear those with just that lens in your left eye. Because when you create less work to create focus on that left eye, it may not have to do as much converging, because your pupil still has to constrict to be able to basically see something up close. So that may be nothing, maybe worse, maybe better. But right now, nothing's great. So right, they're trying to positionally, like, her lens on this left side is turned technically inward. So her eye has to kind of go over, but that's a training aid. So all that to be said, the text was a little worrisome. I don't know if that's anything terrible or if this is just a terrible case of, like, dysfunctional eye stuff going on, but I'll definitely be doing a follow-up to that sometime soon. And I wanted her to give me an update on MRI. Because at this point, then we start thinking like actual, like, and again, you have to kind of start determining where that would be, right? That would have to be on the posterior aspect of the right optic nerve and things like that. So that, like, it kind of leads you to think that something may have happened. But I'll give you an update on that for sure. So I don't really have like, this is what I treated, great outcome, cool. It's like a weird case of, like, and some people may be like, you shouldn't even be playing around with that. Right. But she came in, what you call me? I'm just gonna genius. I'm not a genius.
Oh, don't feed
the other people are not doing their job. Yeah. That's why I'm still in the sandbox. That's the only reason. Like, I literally told her, I think this is way beyond me now. Like, but the only reason I'm here is because I feel like you're kind of still just in the middle of, like, that neuro-ophthalmologist should be running the show at this point. And he is, but she hasn't had that follow-up. And she's literally, she was on the brink of tears. Like, I can't do anything. So that's where you kind of got to play, like, did I adjust her neck? Did I do anything that was, like, aggressive? No, like, absolutely not. But I'm also not managing the case of, like, hey, don't wear those glasses. Like, and I told her, if you buy those readers and you spend $4 and it doesn't do anything, you spend $4. Like, that's benign.
That's cool. I feel like I'm just sitting here though, like, cranking it in my brain too. Like, when you get to hear everything from Z Health and Eric Cobb, you get to hear how he gets to spend almost like sometimes like half a day with somebody.
Mhm.
And like, it's not like you're going to do anything that I want, but like, yeah, those are the cases where you wish that our health made it to where like, heck, I want to add much, but like I could just sit there and brainstorm with you
Mhm.
with like getting one person 1 hour as we talked to me, like we were talking earlier, just to kind of touch on our conversation earlier about Robert Lardner. Yeah, I know I'm going to butcher his last name, but how much like, for instance, with her, like, could we add DNS with all these eye stuff with tongue position? I mean, like, it could go on endlessly and we won't know until we do it. But
Yeah, and with her again, not pulling the trigger or anything else until advanced imaging at this point, just
right.
with the history of it. If she showed up like that today, a little bit different story.
How many times have we said the best clinician knows when it's not their case?
Yeah.
Well, and something with this too, like the neuro, I felt like it almost sounded like you know more about all of that than everybody that she had seen previously. And then so it's like,
Well, and
sometimes it's hard.
a good point on this is there's no negative neuro findings anywhere else. Cranial nerve,
Excellent.
bilateral, lower, upper, like none of all that's normal, right?
Mhm.
A little bit reduced, like the Bensky response. That's been like that forever. Like that's part of this, like.
Well, do you think that maybe her inability, her poor kinesthetic awareness has been influenced by whatever is happening
Well, yeah,
here?
and that's what we talked about. That
was our long combo.
yeah.
Oh,
The
I missed the
likelihood of
beginning
like,
of that.
well, and the likelihood of like poor cerebellar integration in the face of like a visual issue, then it's like what's primary, what's secondary.
Mhm.
Yeah.
Monica had a question. She very politely was like, I have a question. And then Daniel and I just railroaded over.
I was
it.
just- I was just playing role monitor.
Any
Yeah.
other systems affected or?
No. And at first, she was having nausea at first with this stuff, which could just be purely
Makes complete
what's
sense
gone.
with vision.
But that's gone.
Maybe she's just adapted.
Yeah, possibly. Yeah, I thought it was a cool case. I mean, it's definitely not something I treat all the time. And I don't honestly, like, I kind of today wanted to be like, well, you shouldn't really be here. We can discuss all this, but I shouldn't be like doing any treatment until you get the MRI. Neuro-ophthalmologist needs to give us feedback. But then we did talk about that and said, if that MRI is normal and you're still working, like, so this is what, I guess this is a good point to add. I told her, I go, I won't continue the care. Like, there's a doctor named Jeremy Schmo that's up in Minnetonka, Minnesota, that specializes in this stuff. We need to find somebody like him, right? Like, he is seeing high level vestibular concussion, like much higher level. He's got a gyroscope in his office that he's putting people in. Like, we don't get that. So that's the kind of person you need. Yeah. If you're going to deal with something, and that's not me. So I'll help find you somebody. Yeah.
What I like about both these cases, though, is they're both open-ended. So we may have a podcast soon just on filling in.
Who said you could do an open-ended case? I didn't have my case approved.
Is because you do murder mystery podcasts that go on for decades.
And they're highly
and
successful.
now she's watching a show on Netflix about a murder mystery
It's Apple.
podcaster. It's getting
It's
gross.
great.
It's getting gross.
It's great. I have to be careful because Maddox can really absorb what I'm listening to these days.
Yeah, it's a murder podcast. And then you're listening to this, and pretty soon you become a murderer when you start listening to all this
I
stuff.
don't think that happened.
It happens all the time. That's what the show's about.
Stop.
Yeah, have you ever
Really?
seen
Is it?
No, it's not
it's
about that at all.
It's called The Murder.
Have you ever
No,
seen
it's not.
Have you ever seen Dexter? Doesn't
Yeah.
just happen overnight.
It's
Anyways,
Moving
Monica.
on.
sociobiology. Yep.
This one's gonna be so fast.
It's good.
You'll have to find out.
This is where we insert a message from our sponsors to keep people like, it's like a cliffhanger. You'll have to find out.
The murder podcast.
Who did we
Right,
joke
which
about
one?
having a sponsor last week?
Me? No?
No, it was something else that we completely, Hoka's.
Oh.
I thought you were talking about the pin.
Our sponsor is Buffalo Trace.
Buffalo Trace. What kind of wine you got?
This is a Costco special. Matua. Water.
Wait, say it again.
Water?
Oh, I think it's like water. All right, we'll let Monica get after it.
Ready, set, and 40-year-old female parole officer and avid cycler with low back pain. She points lower lumbar spine, kind of local central low back pain. It started in 2018. She doesn't remember anything specific that she was doing, but she's pretty active. I know she used to lift, so it might have been something like that. She can't pinpoint anything. She got imaging when she started having low back pain, and it was an L5-S1 herniation. I did not see her at this point. So I don't particularly know what care she received. I do know that she tried 2 nerve blocks, which were ineffective. And other than that, I don't think she did much else. Bending forward is provocative. Ibuprofen helps a little bit, as well as muscle relaxers to help her sleep. So my initial visit with her was in April, I believe. So it's been a few months. She states that it's aching and occasionally sharp, but it doesn't radiate anywhere, doesn't travel, just focal low back pain. It's worse in the mornings and after strenuous activities. I don't think she reports a ton of pain after cycling, but it's sore. That's it.
Can you concentrate on it?
Yeah. She's on anxiety medication. She has hypothyroidism. She's on birth control, muscle relaxer, and B12 injections.
How old?
For anemia. 40. During my exam, this initial visit, multisegmental flexion was dysfunctional painful. Extension was dysfunctional non-painful. And side glides were fine. Rotation, it was dysfunctional, but not too bad. All lumbar exams were negative, so slump, SLR, etc. Of course, I started with press-ups, which made it worse. Flexion produced no change. So after the first visit,
Did you freeze?
No, I was trying to find a directional preference, of course. Who would I be if I didn't?
Mm-hmm.
And there wasn't really anything. So the first visit, I sent her home with breathing, dead bugs, and a mid-range cat-cow, because that's what I do when nobody's responding. I just say, do it cat-cow, mid-range, see if things get better.
If Monica can't get in range, she's going mid-range.
Mid-range. It doesn't bother her. I'm always about okay, well, let's just send them home with a positive movement experience that doesn't provoke their pain.
I'm with it.
On her second visit, I explored extension again, just to see, might have well exhausted.
It's still worse.
Still worse after. It was one set. So I was just let's see if it makes any change. So I decided to just see if throwing some trunk stability exercises would give us any progress.
I can't wait till Monica's 10 years in practice. She's seen somebody 100 times. They come in, am I really gonna have to do these fucking lumbar extensions again? Yeah, just a set of 10. Let's see what happens. It's my toe. I stubbed it. Yeah, I know.
No.
I know.
The other day, I didn't even start with MDT with somebody, and I don't remember what it was. Oh, it was a knee case. Yeah.
I don't know. 37% knees.
It was a young kid with that Sinding Larson Johansson. Yeah. So didn't even explore end range with that. Where was I? Okay, so we had 4 more visits, and I was just rolling with trunk stability. We did some spinal cars and quadruped, 90-90 get down, static suitcase carries, open books, thoracic extension mobilizations, etc. After a total of 6 visits, she said that cat-cow gives her the most relief when she's feeling a significant amount of pain, but she's in constant 3 out of 10 pain at all times, which that's her new normal or so. She was inquiring about another nerve block, and she was like, well, I've heard maybe it takes 3 in order to feel relief, which some sources would say that it takes a few in order for you to have permanent relief, but I feel like you should have some temporary relief.
So real quick,
Yeah.
I don't think we touched enough on the first visit. She had back pain.
Mm-hmm.
Was there any radiating pain?
No,
Okay.
it doesn't travel. No numbness or tingling. No referral pain into the lower extremities. or
Anything
anywhere
with
else.
SFMA?
Yes,
Okay,
dysfunctional painful inflection.
cool. Okay, all right.
DN and extension. So of course I'm lost movement.
Of course.
Of course, didn't work.
Anything with the hip?
No, her hips were great.
Okay.
All hip tests, range of motion, everything was, it's within normal limits, didn't produce any pain or anything like that. we did another MRI. She was really curious to see if there was anything else going on. I was kind of curious to see if anything else had happened since her initial one. Nothing had changed, though. She still had a small central protrusion at L4-5 and a left central extrusion L5-S1, mostly contained to the ventral epidural fat. So she didn't have anything compressing her spinal cord at all. So we continued working on thoracic mobility and lumbar stability or trunk stability. And she decided to get a second opinion from a neurosurgeon on her own to see about another nerve block. She went after a month of waiting or so, and he said that he doesn't recommend a nerve block because she didn't have success with the other two, and he would not recommend surgery because she doesn't have any radicular symptoms or radiculopathy. So yeah, she came back in last week, told me the news from the neurosurgeon, and she was really frustrated because she waited a month and a half or so to get the appointment, only to talk to the nurse or the PA for maybe 5 minutes, and then the actual doctor for like a minute or two. Unfortunate. But she did say that she has had some improvement in her low back pain since she started seeing me, and that was mainly why she was coming back to just keep going with it. She says she doesn't notice her low back pain as frequently, that she still benefits from the cat cow and some of the other exercises that I had given her. So we're just going to continue going.
How long had she had back pain before she saw you?
Since 2018.
And then what's her history of surgery?
None.
No abdominal surgeries?
Nope.
Any children?
No. She's super healthy. She stays really active. She still cycles.
So do you think this is a chronic pain case?
Yes.
What about like diet overall?
She's relatively healthy. Yeah. Overall lifestyle is very healthy. She stays active in her yard and around the house when she's not actively working out. The only thing is she's sedentary when she's working from home occasionally. So
You checked C1?
you know what? I was gonna toggle a little bit. I was gonna see if Clayton wanted to do it because he was with me in the last
Clayton's here
visit.
for a reason.
Toggle it a little bit and see what happens.
Huh.
But yeah, I'm just giving her a lot of positive movement experiences and see.
We did say reduce flexion in SFMA, right?
Yeah, and painful.
Yeah. Did you suss that out? Break that out?
No, I didn't. I'm not great
That
at the
might be an idea.
breakouts.
But that might be an idea at this point,
Yeah.
right? To like really try to figure out like why.
Super specific.
Stability, flexion restriction? Is it like just mobility somewhere else? Like
Okay.
try to access
Or just
that.
load her up in a Jefferson curl.
Yeah, just fuck. Bend that steel, baby. Yeah.
Well, and one thing I liked about Richard Ohm's last podcast or last thing on his YouTube that, we tagged and I was asking Beau about it was so many people, like none of this other is reproducible, but like, what is there? Like we talked about it 1,000 times. Like, was there a stabilizing strategy? What was their first go-to? And like, he's just saying, hey, if I take one arm off, am I changing everything? Am I taking another arm off? Am I changing anything? Am I changing both arms? Can I do it? And like, can I progress it from there? And I just, it's like every now and then me and you will talk about cases and then I'm just trying to throw out a bunch of questions. Almost always, I feel like you've checked everything I would have checked, but it's one of those where your eyes aren't in front of them, our hands aren't on. And so it sounds like you checked a lot of things.
I apologize. I don't know. I'm sure everyone listening could hear that I was a little preoccupied with Maddox there, so I didn't get all the history. Has she had manual therapy? Has she had physical therapy in the past?
Not
Or
that
did
I
they go
remember.
straight to nerve blocks?
From what I remember, I thought they went straight to.
Okay. So you're her first
Mhm.
kind of entry level or
I
access
might have to
to.
double check on
movement.
that. I
Yeah.
didn't put it in my notes, but she easily could have had other treatment. I'm not sure.
Okay.
I'm getting confused with my patients. I did have somebody that saw like 3 chiropractors and I was the 4th. But I'm pretty sure she hadn't done anything
Okay.
prior.
So it's huge that you're giving her those moments of confidence or giving her confidence in certain movements. I think that's big, to be told, well, we can do a nerve block and they did it twice.
Yeah.
I mean, I can't imagine how I'd feel not in our field, being in a field completely opposite from healthcare. going to a physician and saying you need a nerve block. I mean, that seems kind of extreme for someone you said she's social work. Am I completely off? Parole off. Okay. I was close. Same field, right?
Is it?
Not the same field?
No.
Okay,
No.
but not
Social
healthcare.
component.
No, one person's getting out of prison, the other is trying to just make it in life in general. Not having such
Just
a good
trying
time.
to go to college, you know.
Yeah.
Oh, okay. Well, I apologize. What I basically meant was it is not healthcare.
One's a
don't-
rapper, one's a rapist. Come on, Sloan.
Oh my God.
Break it
I looked
down.
at my
that's
phone for
true.
5 seconds. I have no idea what we're talking about.
Okay.
That's how you know it's a good podcast.
Okay. So, but you take someone that's completely, let's make a judgment call, uneducated in the realm of anatomy, physiology, healthcare.
Why? Because she's parole officer.
I'm just making an assumption here.
Oh, it's dog me for calling somebody a rapper.
It's gotta be really threatening and scary to hear you need nerve blocks. You need 2 nerve blocks.
She wanted another one. I don't think she's that scared.
She
But
just
that's-
wants to be out of
I
pain.
think-
Right. She's desperate at this point. So
I
now
think
I think
that's
I think it
fastest.
can be pretty powerful to have someone now like, hey, pump the brakes. Like we can manage this without like it's not that bad. Like your MRI is not that bad, you know? So
Yeah.
gently tell her that. And
How
that may be
often-
pretty powerful.
How often do you think we get trapped in not looking? So this is a hard question to answer, obviously, because it's hypothetical, but if somebody came in with the same exact scenario with shoulder pain, right? You're kind of like sussing out like McKinsey, you're like, nothing's really, but what if like, instead of like flexion, they just didn't have, flexion, they didn't have terminal flexion.
Mhm.
I think we would treat the shoulder way different than spine. We would be trying to get range of motion.
Yes.
And then the spine, I think we leave it on the table a lot of times.
You're saying like exploring lumbar flexion.
Yeah,
and
but you know what I mean?
redoing lumbar.
Myself included, like we had a case yesterday where
Yeah,
I've seen her
there's
for
not
long
a
time.
disc in a shoulder. So I think the disc is what slows you down and makes you more hesitant with lumbar spine.
Why?
I was going to say, if you look at the research,
I know why. It's a ligament. I know. I'm just giving you the answer of why I would be. Should that slow me down? Probably not, but that's why it does.
Conglomerate of joints and soft tissue. I that's what I'm saying. I think we think about it different.
I'm not saying I'm
and
right, but
I
that's
don't
why.
think we should as much.
Well, in that case, because I definitely agree. I mean, you want to build capacity in the lumbar spine
Mhm.
anyways, but do you do that when they still have pain?
And that's kind of, you know,
Or is
that-
it like the chronic pain case when we talk
I
about
think
extension where you reintroduce the pattern that provokes the pain?
right. And I think that's hard to dictate. I mean, I had a guy that I sent out of here with shoulder stuff that couldn't, cross adduction just hammered. He had to fall, all this stuff. I was like, I think you need a shoulder injection to override pain to then start moving more to incorporate like in range positions. So my thought there was, okay, why don't I think of lumbar spine stuff like that? Like, oh, I'm getting the injection to then get in range in your lumbar spine flexion, extension, whatever it is. So then I can like override that process that just keeps like hitting that like same like stopping. Does that kind of make sense?
But would you do that for the lumbar spine? Say acute low back pain patient, would you send them for an injection immediately instead of just
No.
trying to push through extension?
That's that's why it's a hard question, because based on examination, but where we're saying, I also think flexion restriction is different than an extension restriction. I think all of us would be way more apt to go after an extension restriction. But when it comes to flexion, we're like, there's a mechanism of injury associated with flexion rotation, so we're going to slow down. I think that's a huge fault.
Okay.
I just like overall that I think we've been hyped up on the flexion. That's what Rich has talked about that numerous times,
Yeah.
right? That like the lumbar spine's got to flex. Now that may be pain provoking because we all flex a lot. But that's not like
Well, I think
the
also
rapper.
you've kind of got the green light from the MRI.
Right.
push
That's
it.
what I
Yeah.
was also saying.
You don't
like,
always have the
that
green light.
scenario, if
There's
you
some
had an
hesitancy.
MRI of a shoulder, no labrum pathology, whatever, and you're like, okay, this is
We
because
push
then
it.
it gets into the thought of like adhesive capsulitis. Why don't we ever talk about the lumbar spine as like adhesive vertebralitis, whatever we want to call it? Like you're just not moving, and we got to get you moving to get you out of pain, which is the cat cow, right? So
Mhm.
then it's like, well, okay, why? Stability strategy, you just never access it, whatever. So I think that's, for me, I've had a couple cases where I'm like, God, I just need to really get them to move their lumbar spine more, right? Not
Mhm.
just cat cows, but I have to get it to move better. And like Clayton and he was in on a case the other day. Like I've seen this lady for a long time, same thing. Like she's a tabletop and multi-segmental flexion, like extended at TL junction. Whether I missed it, I forgot it, or whatever. But she's like, I had a she has a splenectomy scar right down here, multiple laparoscopic scars, is having ascending colitis, all these things. And I was like, oh, shit. And I'm trying to increase flexion, like through kind of like DNS, SFMA stuff. And I was like, oh man, those are huge. Right. And that's something that's me. Like I should have caught that stuff.
Well, and the other thing I was going to add is so many times I think I check every box we've already clicked. Like we've already checked everything else. Now I'm like, okay, I got a positive movement here. I know the mechanoreceptors are highest in the joint.
Mm-hmm.
I've got to move it like as much as I can, knowing like I think about Brett and how much he used to emphasize upper cervical and how much like movement we have going on there. Like I have no idea if I'm adjusting C1, C2. I just know that if I put input right here, that I could be affecting over here. And so I know that if I can get low back, mid back, if I can get that joint moving like I'm supposed to, it's like I'm getting the joint moving, and then maybe I start doing extensions.
You're bombing the area with
Lynn Fay, 44 visits and you're better. No, I'm not saying he does that. But like, that's maybe one of those cases. You just have to sit there and like work a lot. And I think that's also like something we miss. Like that patient I saw last night with like, I've seen her a long time, but I got her out of pain, right? The function, I was like, hey, this is going to take a long time to change. Well, what if I just sat there and like worked with her a lot more instead of me saying, hey, go do these drills out of here, and really like manually went after it. And she's seen vast improvement, but like we're having little hiccups, right? Now, me missing that point changes what I would have probably worked on anyways. But let's say it's just like, let's say you broke out SFMA and you're like, it's literally a lumbar flexion restriction, right? Like that's what it is. Well, how much time do we think that's going to take? Probably a lot. Right, if you honestly think about it.
How old is she?
40 years old, takes a long time to get like that, right? Just living in extension. So I think that takes a lot of work.
Then there's the cycling component where she's constantly in lumbar flexion.
Which is interesting, right?
Mm-hmm.
Yeah. So she was doing 100 miles.
So that makes me think immediately what? Stability strategy.
Mm-hmm.
Like you're
Because
absolutely.
are we ever out of flexion?
The other thing I uncovered that I just thought of is that she sucks at exhaling.
Which is a flexion
Big.
moment.
Yeah. So we were doing some planks on the ball with prolonged exhales, and she was having a very hard time.
That's a good
her go-to is just to hold her breath.
Yeah.
So
Something
really
there,
done that as well.
something there to also just check out, in my opinion, would be like parasitic motion between like rib cage and spine again.
Mhm.
Like, is she actually stuck in extension
like a
here?
hyperinflated.
And that's why she can't flex out. And that's why she has a hard time exhaling. But yeah, I mean, that's a really good call. That's
like
great
the-
Cook stuff, right?
Yeah.
Like prolonged exhale, flexion patterning, all that stuff.
Because I think of that, and then I think if I can't ever get into a parasympathetic state, like of course,
Yeah,
like
it's
yeah, I'm just
yeah,
tired all
prolonged
the time.
exhale. Yeah, that's a good call too. Man, look at these studs pulling out freaking like shotgun shells left and right.
Pretty much 3 new.
But he doesn't. Oh, 3 cases.
Yeah,
I thought you were
but-
saying 3 pretty good clinicians and the moderator.
No. Just we all have 3 cases that are just so not textbook,
Yeah.
No MDT for that lady.
No.
And what's
But
so
you
hard is
ruled it
we always
out.
want to
You
bring those
insisted.
here to this. And so,
Mhm.
as soon as I think I have my case, I talk to Beau, and then he tells me some crazy case that just happened to walk in the door, and I'm like, dang
And
it,
he's
my case sounds
sending to
so
a
freaking boring.
neuro-ophthalmologist.
Which again, I bring up those cases, like your case is way more common.
Uh-huh.
Somebody's stuck in a position they can't get out of. Way more common. Then that opens up the gambit of like, well, there's like 10 different treatments for 10 different people with the exact same thing. Mine's a one-off, right? It's interesting because how are you going to catch that? Right? How are you going to, if somebody comes in with, if you're a chiropractor, you're going to have a ton of people come in with vertigo. It's your primary. First of all, do you know how
Brain
to
rot.
identify what type of vertigo it is? Should you be treating it all? Do you have the access and the scope to treat it within your state? And then from there, like, what all adds into vertigo, right? Like I used to, when I first was in practice, I just thought there was a cervicogenic component and a vestibular component. I knew how to rule those 2 in and out. I wasn't looking at eye stuff and all the other, like, at all. So like, I still got success with a lot of stuff, but like I could have done better, right?
Mhm. Which is basically what we were talking about earlier. Like, what is our conversation going to look like in 10 years?
Mm-hmm. Probably the same, just a
Yeah.
lot more simple because we're just like,
Mhm.
you're idiots. Like
Yeah.
we knew what we were doing the whole time. Like Monica would be like, man, that person just needed to flex. Should have just like pushed them.
Gas pedal.
We call this the gas pedal adjustment.
What if we're all in 10 years like, damn it, ring dingers, Jefferson curls, and what else?
Gas pedals.
Gas pedals. That's
I
where you go.
cringe when patients ask me about the ring dinger. They're like, what about the one where you put the towel around your neck? I'm like, no.
You're like,
No.
yeah, you're like all out of an 8 today. So
I was just looking at usually my go-to was always, I would never let it happen to me. I think my go-to nowadays, now that I'm probably getting to where I got too much like Beau in me, where now I would be like, I don't know, let's find out.
Here, I'll go grab a towel. I'll be back. Clayton, are they teaching ring dingers in school these days?
no. What an atrocity.
Wow, I would not pay those
That
student
guy's
loans.
he's a celebrity.
He drives a Lambo,
I mean,
Does he
Is
really?
this license plate ring dinger?
probably.
I think it says ring dinger.
if Will Smith kills zombies and he's a celebrity, I want to learn how to kill zombies. So I don't know what the schools are doing nowadays.
Yeah.
So
A shame, really letting you down. Okay, but let's bring Clayton into this conversation. Put you on the spot. Anything cool you saw this week?
Everything you guys just talked.
All these cases.
all right. Well, before we jump off here, make sure you go.
Do we not have a new review?
No, we don't. That's why I'm saying what I'm saying. Go subscribe to the podcast on Spotify or Apple. Leave us a review. If you don't leave us a review and you subscribe, I will find you. No, I have no
Liam
find you,
Neeson
because
is-
I don't know. Yeah.
They bring me a lot of joy, you guys.
Well, I was about to say, and like the go-to from here on out is, we can't do another week unless you have a good review.
Ooh.
And so that either means if you listen, you have to review, or it means say all of every people who listen every week, they do review. It means you got to tell somebody else.
I will say this. I saw Pete Roy gave us a shout out on the MPI update list.
Hey,
It's
thanks,
like a
Pete.
podcast to listen to.
Thanks, Pete.
Farm Week in Review. So thanks.
One
man.
more note.
Yo.
Yeah.
If you want to send us cookies, we're up for that too.
Yeah, DoorDash is 215 Narrows Parkway.
Sweet A.
I mean, I'm not going to disagree with that. Yeah.
Solid
DM me
point.
for the address. You can ship cookies.
There you go. We're game. All right. Any last words of wisdom?
Roughly 2 o'clock in 2 weeks.
See you there.
See ya.